Hey, welcome back to another exciting program, live and direct with Dr. G. I'm Dr. G, and I'm happy and excited because we're going to talk today about women's reproductive sexual health. I say activity. They told me not to say that, but I said it anyway. And so I have two young ladies that are here today to lead and guide our discussion. So sit back, relax, and as always, remember to like, share, tag, but most importantly, share us with your friends. So I've already been corrected one time today. I'm supposed to say like, share, and subscribe.
That's right.
And that's what happens when you have two dynamic individuals like I do today. I'm going to introduce Ashkia Pinkney. Ashkia Pinkney is a graduate of Spelman College, but she is from Darlington, South Carolina, and she graduated also from the Medical University of South Carolina, did her residency at the University of Tennessee in Memphis, and she's been at Carolina Pines for about a year. So thank you to Dr. Pinkney for being here with me tonight.
Thank you for having me, Dr. G.
Yes, ma'am. And on my left, I have Dr. Casey Wadsworth, hometown Pageland, South Carolina. College of Charleston is where she graduated. Medical school, of course, MUSC is where she did her residency, and she too is at Carolina Pines. She's been there for about 18 months, and I'm going to let them talk a little bit about what they do, and then we're going to get into some questions. Is that okay?
Sounds good.
All right, so I'll let you start, Dr. Wadsworth.
Yes. So, as stated, I'm from Pageland, South Carolina, moved down to Charleston for college, med school, and residency. And I started out with my career here in Hartsville, South Carolina, where I joined the group at Carolina Pines. I see women from teenage years all the way through menopause and treat a lot of different conditions, which I absolutely love.
Okay, all right, thank you. And Dr. Pinkney?
Well, like you said, my name is Dr. Pinkney. I'm originally from Darlington, South Carolina. I attended Spelman College, and I left this place for about 17 years. And the pandemic brought me back home to take care of the women that I love and support. Just like Dr. Wadsworth, I'm at Carolina Pines. I see all women of all ages and all phases of their life, and it's truly a joy to take care of our population.
Okay, and so ladies, I'm going to go ahead and tell you now, I like to ask questions, and I'm thinking that I'm asking questions that men and women would like to know. But before I even get into that, I want to have one of you, if you would, just discern between health disparities and health care disparities. And we're going to talk particularly, or I'm going to be asking particularly about women of color, because you serve a diverse population, no doubt,
That's correct.
here in Hartsville, but predominantly those in the PD region that you look after are women of color. Is that correct?
That's
Yes.
correct.
Talk about a little bit between the two.
Yes. So when we think about health versus health care disparities, we want to get to the root and figure out, the differences between those. So a health disparity is something we think about in terms of a diagnosis. What is a particular group being diagnosed with more often or more commonly than other ethnicity groups? Okay. As far as a health care disparity, that delves into the care that patients are receiving, when they're coming into the clinic, when they're coming into the hospital. Are you being treated appropriately? Are your concerns being taken seriously? And so that is how we define a health disparity versus a health care disparity.
Okay.
In regards to the health disparities, we know that within our particular community, the African American community, some health disparities are more prevalent among us because of our diet, because of our exercise, because of our culture in general. So we know that African Americans are more likely to suffer from hypertension. We know that we're more likely to suffer.
Now, hypertension, hold on. When you say hypertension, break that down, because
Okay, my
that's a
bad.
big word. That's like
about-
5 syllables.
That was.
Tell people what that is.
Hypertension. Okay, high blood pressure.
High blood pressure.
blood, which what we call
High
it.
sugar.
High sugar, the
okay.
diabetes, sugar diabetes,
Okay,
which is still
okay.
diabetes.
Okay.
But all of those things affect our culture at a larger amount just because of our diet and the things that we eat. So those will be the examples of health disparities. Like Dr. Wadsworth said, healthcare disparities are what we face when we go into a clinic, when we go into a hospital. What is the care we're receiving from our providers?
Yeah. And access is also included in that.
Very much so.
And here, having access to good medical care is not as prevalent as it would be in larger cities. Is that correct?
Absolutely. So we are in what we would call a rural area, and specifically, obviously, we're in South Carolina. So we're in a rural area of South Carolina, and our specialty in particular, there are maternity care deserts. There are many, many counties in South Carolina with no obstetrics provider whatsoever, which is one, very unfortunate, but also very dangerous. Pregnancy is one of the most dangerous times of a woman's life. And so, considering the fact that there are counties miles and miles and miles with no obstetric care providers, babies are being born regardless, right. Whether it's in a hospital and you've gotten care, whether it's at home and you haven't received any care whatsoever. And so, healthcare disparities with that are tremendous, and healthcare deserts are something that, Carolina Pines is actually trying to combat with Dr. Pinkney and myself here in Hartsville.
Yeah, they love to call us like hometown girls. We're hometown girls. That's what our CEO calls us.
You are.
And that's because we have a heart for this community, and that's what brought us back home. We knew that we can go out anywhere in the world to do what we're doing, but the fact that we can be home and see the people that knew us when we were still in high school. I was at Mayo, and they knew who we were then, and to see where we are now, I think that helps to alleviate some of their fear of coming into a healthcare system and facing those disparities, because we're from here. I know what we're about. I know what we face. I know about that good burger at that corner store over there, so I know all those things. So I think that that's the biggest thing. What we're here to combat is that healthcare disparity.
And so one of the things that comes to my mind when I think about you two ladies being homegrown from here, mm-hmm. and knowing exactly what it means to know where the good burger joint is, or where to get those hog maw and neck bones. What are we doing, or what are you doing, or what are you seeing that needs to be done to help bring our youth up so that they can know how to eat healthy, how to be better prepared when it comes to handling sexual situations where they might find themselves pregnant, right? Mm-hmm. And trying to hide it, right? Mm-hmm. And then the mother goes 6, 7, 8 months without any prenatal. Talk about that a little bit. What can be done, or what are you seeing in your particular area to address that?
Absolutely. So I think, obviously, in our field, one of the first points is in clinic. So we do have a lot of wonderful, wonderful moms in this community that bring in their teenage daughters. Like, just because you're not getting a speculum exam, just because you're not sexually active, that doesn't mean that you don't need a gynecologist yet.
Right.
So we recommend that young girls actually start seeing an OBGYN, even around between 13 and 15 years old. And so that gets them in, that gets them comfortable with the provider, so that when they have issues, when they have questions, when they have their sexual debut, they have someone they feel comfortable enough discussing different things with, and being vulnerable with. But in addition to obviously meeting them in the clinic, which is our most likely point of seeing them initially, going out into the community and educating them. So volunteering at schools, volunteering at health fairs, those are really important places where we can meet our youth.
And I like to, my thought process is educate a mom, educate a whole family. So when that mom comes into my office, any myths that she has, like cervical cancer is hereditary, or the IUD gonna get you pregnant faster, like all of those things, I like to.
Wait a minute, that's not true?
No, Lord, please, that's gonna have to be a whole nother episode. But I feel as though, like, I like to dispel those myths. Like, I like to sit there and take that time to educate the mom in hope and prayers that she'll go out and educate her family. Because if I can teach the mom about her menstrual cycle, then prayerfully she'll go to her daughter and she'll teach them, and they'll go to her friend, and this, that, and the other. I think a big disservice that we're doing in South Carolina is the fact that we're not teaching sexual education anymore.
Okay.
And so that's going to lead to even more health disparities and health care disparities. And it also increases the lower socioeconomic status, because if you have younger people who can't provide for their children, having more children, then you're increasing the poverty. So I think that, like Dr. Wadsworth mentioned, going into communities and educating them, and also taking that time to educate our patients so that we can have a larger impact in the people that we don't necessarily come in contact with.
Okay, now you said something that I have to speak on. You said if you educate the mother, you've educated the family, if I heard that correctly.
You did.
And I'm not going to discount that. Let me just go ahead and go on record and saying that I believe women are smarter than men.
Oh, why, thank you.
Well, I just say that because, I have a
wife
mother,
trained
a
you
wife,
well.
and a daughter. But in all seriousness, I do find myself wondering, how can we better educate young men? And don't get me wrong, I heard what you said, Dr. Wadsworth, and that is we should look to have young ladies in front of doctors, whether it be in a clinic or at an established healthcare provider by way of insurance. And not everyone has insurance, but
Absolutely.
what can we do, or what have you thought about that can help young men? Because we need to be educated. Like, for example, I didn't know the thing about the IED.
It's not true.
Yeah, well, I wish I'd have known that years ago.
I think that's a really important point, and a lot of what we'll mention tonight will be directed at young girls and women, because we are obstetrics and gynecology providers, and so our population is women or individuals with uteri. However, young men should absolutely start seeing their primary care doctors early. Diabetes, high blood pressure, some of that is coming. It's getting younger and younger to where, individuals are being diagnosed. So whereas individuals treat us as their primary care provider, as OBGYNs, young men, they can absolutely access a primary care doctor, a pediatrician, and start having those early discussions with them as well. This is absolutely not to discount them, because I'm sure young men have issues that they need to get out and discuss, and learn more about and be educated on earlier, rather than later.
And I say young men because young men grow up to be old men like myself. But the more educated we are, to your point about educating the family, the woman, the conversation flows differently. When all parties know that there's an expectancy that we're going to take care of our bodies by way of seeing our doctors on a regular basis, and we're going to discuss things around the house that relate to our health.
Yes.
And our kids need to see that. When you talk about disparities, you were talking a moment ago about the birth rates, or I think you mentioned the birth rates. Childhood, what's the word that I'm looking for when
Infant mortality?
infant mortality. I was going to say childhood mortality, but infant mortality is higher here than it is in many of the counties around the state.
Yes.
Because we're in a rural area. So like Dr. Wadsworth mentioned before, it's the access to care. So if a woman, just give you perspective, if you're a woman and you have one car for your family, you have 3 children, you're pregnant right now, and the doctor's office is an hour away. Are you really going to drive an hour away for us to see you for 15, 20 minutes after you wait an hour and a half? That it's just not accessible to them, and it doesn't necessarily fit their particular worldview. Other people, it's like, yeah, get off work and just go to your doctor's appointment. No, she works a 12-hour shift. Right. She has no access to her phone. How is she supposed to get off work and go to her doctor's appointment? So it's like we have to meet the people where they are. I think that the pandemic, the big thing that it taught us in healthcare is that telehealth is still a way to reach people, right? So that you just call your doctor up on the phone and you have a conversation with them. No, we can't necessarily examine you, but we can triage you, or we can look at you and talk to you and try to assess if there are any things that we can address over the phone, and then we can see, okay, well, I need you to definitely to come in. But our mortality rate is not going to get any better until more physicians are coming to these areas to take care of these patients, or if we're able to get approval to get back to doing telehealth visits so that we can access them if they can't access us.
And I'm glad you said telehealth, and I wanted to get you to expound on that a little bit, because telehealth is fairly new. And what I mean by that is I can remember around 2014, 15, the push was for telehealth for rural communities like we are in, and then it kind of went away. But then when COVID came around, it got a push again. But talk about telehealth.
So telehealth is where individuals can have a visit via Zoom or FaceTime or some type of video conferencing system, because for every complaint, they don't necessarily need a physical exam. And so, listening to a patient, hearing what their concerns are, hearing what their symptoms are, a lot of times we can diagnose what is going on with that. However, COVID did a number. It brought in telehealth, and now that we are outside of that pandemic window, insurances are now trying to not cover that. So that is going to create yet another barrier that telehealth was able to break down. And so if insurance isn't covering these visits, physicians and hospitals aren't getting paid, and so then those telehealth visits are outlawed, and then we have more patients that are unable to access care. Just like we've mentioned before, you have a huge family, you have one car, you have a job, you have to take this child here, that child there, and squeezing in a visit an hour away is not as simple, as what the system would make you think it is. So I think telehealth was huge for the pandemic, and it could be huge moving forward. But the systems in place that, are supposed to make sure that patients are getting taken care of appropriately, when they take things away like telehealth, it makes our job much harder, and it makes America much sicker.
And it's amazing too how we learned so much during the time of COVID. And granted, it was we did the best we could, and not just healthcare, but in education. Me, of course, at the time I was a superintendent, and we had to learn a lot on the fly. Those lessons that we learned, of course, it sounds like what I'm hearing from you, they're soon forgotten. It's not like it can't be done. It's almost like it shall not be done. So that's interesting to hear that the same thing is happening in healthcare. I want to switch topics if I can for a moment, because I'm seeing more and more ladies in older stages of life turn up pregnant. and
that 57-year-old one that was on Shade Room, that was a yeah.
I like to hear your thoughts about that as it relates to, because we were having a conversation earlier about, is there such a thing as there's a time to shut it down?
Never.
Okay.
If you don't use it, you lose it.
If you don't use it, and that's funny you say that. I tell my wife that all the time.
Don't let us get in trouble. We're not trying to get in trouble.
She can't get pregnant. But again, she can still use it. So
That's right.
I am, again, seeing a lot of women, or more women than I've ever seen before at older stages of life, that are deciding to have children.
Yes.
Is there, and I'm sure there is some risk to that. Can you talk about that a little bit?
So technically, we call it advanced maternal age, or a geriatric pregnancy. And so that's anyone that gets pregnant over the age of 35. And so when we're seeing these people on
over 35.
Right. When we're seeing these people online that are like 56 and in their 60s and things like that, 9 times out of 10, they had to go to a reproductive endocrinologist or a specialized pregnancy person, if I want to put it in my layman's words.
So they're not getting it the old fashioned way.
No. This ain't Sarah in the Bible. Jesus did not drop that baby in that woman.
Well, it wasn't Jesus. It wasn't
God,
Jesus.
the Holy Spirit did not put that baby in that woman. He is not the Father.
Okay, all right.
But no, majority of the time, so like, for instance, Naomi Campbell, she did a surrogate. Tyra did a surrogate. Janet Jackson, we don't know if she did a surrogate, but all of them were well over the age of 35 when they had their first child.
No, I'm talking about from a local scene.
Oh Lord,
You know, I mean, are you seeing that in your?
rarely. Yeah.
So I wouldn't say I've seen as high as, 55, 60 years old for spontaneous conception or even IVF for that matter. But I think it's very important to note that the age that women are getting pregnant now is getting older. Women are holding careers. I mean, ourselves,
Yeah,
for
we don't
example,
have any children.
we went to
Oh, you don't have children? Okay.
no, me either. But we had 12, 13, 14 plus years of training after high school. And so our focus was not on starting a family, getting married, while we're trying to achieve these career milestones. And so the fact that women are working and, becoming breadwinners of the family, XYZ, and we are pushing off childbearing a few years to achieve these milestones with our career. Yes, we are seeing women older, but we are also seeing, reproductive infertility and endocrinology increasing. So women are freezing their eggs so that when they are pregnant at 38, 40 years old, they're able to have a healthier pregnancy because those pregnancies are conceived with 30-year-old eggs, 33-year-old eggs.
Okay.
And so, yes, I think that's something that our society is seeing now. Obviously, the older you are when you are pregnant, that does come with some risk factors. We want to make sure that your heart is healthy. We want to make sure that your blood vessels are healthy. All of these are major organ systems that are impacted by pregnancy. But we are absolutely seeing the age for pregnancy increase.
Okay. And I didn't know you didn't have kids, so
Yeah, so you
I don't-
kind of stepping
I don't-
on
yeah,
our toes.
I don't want
Talking about
anyone to
old women getting
I didn't
pregnant.
say, I said women are older having babies. I didn't realize
You can
what we were
politicize it if
anyway.
you want to.
Let me get
It's okay.
let me get to the other side of that too, because as I said, I do a lot of reading, and I'm sure you have to do a lot of reading, but you also get to see some of the things that are going on and interacting with folks. I'm also seeing that women that are older are becoming more susceptible to high-risk diseases.
Yes, because it's the thought process. I can't get pregnant, so what of it? You know what I'm saying? So
But just a minute ago, you said they're not.
I mean,
getting it
yes.
the old-fashioned way.
Listen. So if you go use it don't lose it, but protect it. Like you got to put all those words together because, like you mentioned, yes, when you get older, there is a decreased likelihood of you having a spontaneous conception, but it's not impossible. So I've had so many women come in saying, I didn't think I could get pregnant. Like, but who told you that? Like, did you ever go to a physician? Did you have your uterus removed? Like, just because you weren't able to get pregnant with one person over 5 years does not mean that you can't go into another relationship and get pregnant. And so that's the reality of it, is the fact that you need to still protect yourself until you can confirm that either you won't get pregnant or you won't contract a communicable disease.
Yeah.
I think another good point is, and I have a large patient population that are in their 40s, 50s. They've been married for 20, 30 years, but they were never tested before they were married. And so, people have multiple sexual partners, and when we're younger and we're having fun, but we're not getting tested, sometimes that comes to bite us a little later on. A very well-known sexually transmitted disease, trichomonas, lives around forever. Literally forever. There are women that will have trichomonas living out in the vagina for 30, 40 years, and they come in finally for an exam with us. We test for STDs, and they are absolutely distraught, rightfully so, but they are distraught. Like, I have not been unfaithful to my husband. I feel like he has not been unfaithful to me.
Somebody lying.
What is going on?
Don't
What is
do
going
that.
on? But when we ask the questions, well, when was the last time you were
don't know.
tested? They have no idea. They have not been tested the entirety of their marriage, and who knows how long before the marriage. And so I have to sit down with a lot of patients and let them know this does not mean your husband or yourself, either of you, were
unfaithful
or seeing someone outside of your union. This just means you never got tested before, and had you, this would have been found, this would have been treated. We wouldn't be having these issues now, and you second guessing what's going on.
What specific tests? And I didn't know that, and I'm glad to hear it. No.
Take a note. Write it down. You want me to write it down?
The reason I say that is because you don't want to find yourself involved in a conversation. I don't want to find myself involved in a conversation with my wife about something that either of us could have carried for years. Because I'm not going to buy it, and I doubt very seriously she's going to buy it. But now that you've said this, what particular test, specifically, what test should you be having?
Yes.
At early ages and often.
So I'm glad you asked that, because I actually had a patient today that came in for her annual exam, and we were doing a pap smear, and I asked her before I got started with her exam, would you like STD testing as well? And she said, well, I thought that was the pap smear. No.
I thought it was the pap smear too.
That is absolutely not.
I don't even have nothing
to pap. You ain't got nothing to pap or smear.
But I thought all that was together.
So with the pap smear, and I do my absolute best to educate my patients every time, with the pap smear, we are looking for changes that lead to cervical cancer. And so patients think because we have a speculum in the vagina and we're doing a swab, of course they're testing for STDs. No, we are looking for your risk of cervical cancer with a pap smear. An STD test is completely different. So in our clinic, we have something called a new swab. I hope that doesn't get us canceled for mentioning that name. But that in particular, it looks for bacteria that cause bacterial vaginosis in a woman, that looks for fungi that cause yeast infections, but it also looks for the STDs, gonorrhea, chlamydia, and trichomonas, the one that we talked about.
And it's called a new swab?
It's called a new swab. But
it's a new day.
Different clinics have differing swabs that they use to test for STDs. Okay. And then I also encourage my patients, especially, if you're sexually active, if you have multiple partners, to also get tested for syphilis and HIV at least once a year. Many people come in every single day and they haven't been tested for HIV in 5 years, 10 years.
Wow.
And again, in our field, we absolutely don't want the first time you're notified of an HIV diagnosis to be when you're coming in for your new OB pregnancy, pregnancy visit. And so getting these things done every year, very, very helpful. And then you feel even more empowered, when you get a new sexual partner or whatnot, to be like, oh yeah, I was just tested. Here are my results.
Let me see yours.
And you're that much more comfortable, being intimate, knowing that you're good, your partner is good.
Right. And so when you're going in as a male or female, you ask for an STD screen. Screen me for all sexually transmitted infections and diseases. And the importance of that is that a lot of times people just, oh, well, the doctor should have just known to test me for that. Like, well, why? You know what I'm saying? No, because then that's an upcharge sometimes with some insurances, and then you're coming at me
Lord.
like, well, my husband is faithful. Did you hear something? I didn't ask for that. And so we have to have those conversations.
Yes. Don't put the husbands on the spot.
See?
Let's go ahead and make sure we get that cleared up right now.
There's certain ages that are at higher risk for sexually transmitted infections. And like you mentioned before, we are seeing an uptake in the older menopausal women where they're having sexually transmitted infections. But regardless of that, anytime you're entering into a new sexual relationship, in order to best equip yourself and to ensure your health, you both should come together and show your STD screening so that we know where we're standing, we know where we are. Like if this is going to be a relationship that we want to pursue, that should be a first conversation.
Absolutely.
So, I'm thinking as I'm listening to this, for couples that have been married for quite some time, is there a point where they have to now begin to think, hey, we never got tested. Let's go back and ask specifically for tests related to STDs. And you mentioned a moment ago that you have to ask for, when I go to the dentist, I say my tooth is hurting. And, the dentist, he'll fix the tooth. He'll say, hey, by the way, you have 3 cavities, and you also need a root canal.
Sound like a
and
mechanic.
need a-
Oh, and let me get your oil.
Yeah,
And
I mean,
no,
so they don't do that at the doctor.
The
no.
difference is some things are visible.
Okay.
STDs are not always visible to the eye. Most STDs are asymptomatic. And so it's not like you can come in and say, we can look in there and be like, oh,
Whoa.
yeah, you got this looking like chlamydia.
Gonorrhea.
This looks like gonorrhea. No, that is not always visible
Well,
to
for,
the
for
eye.
men, we were always taught if it burns when you
Oh, Lord.
First
it
of all,
burns
that's a
when you
UTI.
right.
Look different.
Look different. I mean, sometimes it'll burn, sometimes it won't, and you just keep burning everybody in the neighborhood.
no. So again, there's a lot for us to learn by having
Definitely.
you ladies here today, and I know we're almost at the end of our time here, and so I do want to say thank you. But before we close out, I do want to hear your thoughts on what is the most pressing, or what is one of your most pressing thoughts for how we can make a change here in health and healthcare for women of color here in our county.
That's a really good final thought.
I would say that the important thing is to find you a provider that you feel like you can trust and that you can talk to.
Okay.
A lot of times in rural healthcare, you feel rushed. You feel as if the doctor's not listening. The doctor's not going to listen anyway. They're just going to push pills. But you need to be able to develop that relationship. And it's hard here because there are not that many providers to provide care in a caring manner. But try your best to find someone that you can relate to. And even if you have to say, hold on, doc, can you explain that? Fall on your sword. We're very prideful in the South. We don't want to seem like we don't know anything.
Right.
But this is your health. And you walking away with 12 different medicines because you've seen this doctor and you told him 12 different complaints, that does not address the root issue. So you need to be able to communicate with them and trust that their decision, or that you all are coming to a mutual decision that's best for you.
Okay. All right. Find someone that you can talk to and trust and confide in.
I would absolutely echo that. I think having a trustworthy provider that you can be vulnerable with is by and far, the most important thing that you can do for your health. But then also using social media keeping it at a distance. There are a lot of influencers with zero medical knowledge whatsoever, zero medical training whatsoever, putting out misinformation on social media. And so those individuals that are not getting care as they should, they are using social media as their doctor, as their clinician, and thinking, oh, this is what I have, this is what I need to take, these are the herbs I need to take. No. Do not confuse our medical degrees with the TikTok influencer that got her information from Wikipedia. If you see something on social media that you're concerned about, that you think may be going on with you, find that trusted provider. Bring us that information so we can get down to what's real and what's not.
Okay. All right. There we go. Now, I do want to say that my doctorate is in education. And it's always great to have medical doctors on to talk about medicine and medical situations, because I don't want anyone to misinterpret when I say live and direct with Dr. G. I'm a medical doctor. It's education. But I am smart enough to have 2 MDs on the show to talk about things. And if nothing else, I do want everyone to know that our goal always is to provide information that's going to be useful, practical, a little entertaining, but at the same time, we want you to be aware and knowledgeable of how and when you proceed. I hope you learned something today. Like, share, subscribe. But most importantly, share this with friends. I'm looking forward to doing a part 2, and I say that because I learned a lot. I can't wait to get home and tell my wife, we're going to the doctor.
No, that's right.
I don't know if she's been screened or not.
Listen.
I need to know.
That's all
Clean
right.
slate.
Send her our
Send
way.
her our
We'll get it
way.
right.
Carolina Pine.
Thank you, Live and Direct with Dr. G. Can't wait to see you next time.